really technical. Right, so it's about 5:30, so I think we'll get started. Welcome, everyone. Before we get started with tonight's session, for the students, just a couple of reminders. So next week's session is violence against women and children. And for the registered students, we're going to do a grab a guy session. So just to remind you, we invite our registered students to bring a friend, colleague, coworker, significant other, some guy, any male that you can get your hands on, and convince to come to this session to join our discussion on violence against women. And so we'll do a grab a guy session later in the series, I think, on reproductive health rights. Yeah. Also, there's a sign-in sheet. There's a number of sign-in sheets that are going around. So just go ahead and pass those to your neighbor, and hopefully everyone will see those tonight. So this evening, we'll discuss barriers to healthcare for immigrating women and children. So before we get started, I'll just put up our learning objectives for tonight. So these will be to identify barriers to access of healthcare, to provide specific examples of where policy and laws could be changed to improve access to healthcare, and to discuss ways that the root causes of migration can affect access to different services. We have a terrific panel lined up for tonight. We'll just do some brief introductions as people continue filing in. Amy Alexander is an attorney with the Northwest Justice Project. She's developing a medical legal partnership with CMAR Community Health Centers. Amy provides training to providers and direct client services to the Burien and Seattle CMAR clinics. Amy will discuss her work with these projects and how clients can overcome barriers to accessing health care. Jorge Barron is the executive director of the Northwest Immigrant Rights Project. Jorge is originally from Colombia. He served as a law clerk for the U.S. Court of Appeals for the Ninth Circuit in Seattle. In 2008, Jorge was appointed by Governor Gregoire to serve on Washington's New Americans Policy Council, and we look forward to hearing his thoughts about immigration issues. Awa Kone is a partner in the Seattle Immigration and Family Law Group and director of the Côte d'Ivoire Health Projects for Health Alliance International in the UW Department of Global Health. She's a native of Côte d'Ivoire. Her community involvement includes the African Women's Communities Network, Yesler Terrace Health Clinic, the Commission on African American Affairs, the Seattle Human Rights Commission, Women in Common, and the National African Immigrant and Refugee Women's Network. Awa will be discussing the problem of domestic violence against women in the Seattle Somali community. Alexandra Molnar is a physician at the International Medicine Clinic at Harborview Medical Center in Seattle and also faculty at UW Medicine. She cares for many women who have undergone female genital cutting and also trains medical students in this area. She is also a volunteer physician for Health Right International, completing medical affidavits for asylum seekers with FGM and other issues. Alexandra will present an overview of our topic tonight and also discuss some patient experience. Faria Mohammed is a family advocate for the Southwest Youth and Family Services. She hails from Somalia and is a leader in organizing and mobilizing the Seattle Somali community. Prior to her work with Southwest, Faria worked as an advocate for the Refugee Women's Alliance, REWA. For more than 15 years, she has worked in assisting and advocating for domestic violence victims within the refugee and immigrant communities. Faria has been a member of numerous community organizations, including the African Community Network, National African Immigrant and Refugee Women's Network. She also created the Somali Families Safety Task Force, a group providing outreach with the local Somali community in order to educate families on ways to prevent domestic violence. Faria is also in her second year of the master's program in the School of Social Work, and she will share with us some thoughts from the community on this project. And so with that, we can begin with Dr. Alexandra Molnar.
Excited to be here tonight, and I'm really happy that so many people are interested in this topic that is very near and dear to my heart. As Jen mentioned, I am a physician and I care for many immigrant and refugee women and men at Harborview. And we see a lot of barriers, but we also see a lot of resources, a lot of wonderful programs, and I'm going to share a little bit about barriers and a little bit about some of the resources. I'd like to start with the story of a patient who I care for. Just to give you a sense of how I'm going to spend the next few minutes, I'll tell a story, talk a little bit about how that illustrates some barriers and resources, and I'll back up and try and give a brief overview of this idea of web of effects, barriers, and resources that are out there, and then wrap up with just a short outline of some of the different paths that immigrants take to the United States and how the path that people take affects their access to services. Well, let's start with Maria. She is a woman that I met a few years ago. I met her, she was in her mid-20s. She had come to the United States as an unauthorized immigrant when she was a toddler with her family. She's what we would think of as a dreamer now. Her family was very excited to be here, wanted her to be a real American, and did not allow Spanish to be spoken. Grew up not speaking Spanish, and in fact feels pretty uncomfortable with Spanish now and has a lot of fear around being deported back to Mexico, to a place where she would have trouble communicating. Because of her unauthorized status, she had a lot of difficulty with opportunities. She was able to make it through high school, but then trying to go to college, get loans for college, get gainful employment, there were a lot of barriers to that. And she had had a lot of family support growing up, but had recently lost a lot of her family support because she had shared with her family that she was a lesbian, and her family was not able to share support with her after that. She was feeling very alone when I met her, very fearful about deportation, very depressed about her lack of options for her future. Growing up, she had had limited access to preventive care. She, for example, had not received the HPV vaccine to help prevent cervical cancer. Although she was of age where she should have by then had a couple of pap smears, she had never had a... And she didn't see how she could ever afford those kinds of preventative care. She originally came to my attention because she had gone to a few different clinics in the area looking for care. Hoping that someone could see her because her periods had become irregular and she was bleeding more often, and she didn't know if there was something wrong. She had been turned away from the two clinics that she had gone to initially because she could not pay for care and she did not have access to it. I was lucky that I was in a clinic that could see someone that had a fund for free care in a very generous state in a time in U.S. history when they were able to be more generous. I was able to see her, diagnose her early cervical cancer, and get her the treatment that she needed. She was able to go on and be healthy. She still had lots of struggles, lots of barriers to her own ongoing health care, but I was pleased that I was able, because of where I was and the time in history and the place we were, get the resources she needed. And Maria's story illustrates some of these issues that I have up here, and so now I want to step back and look more broadly at this web of effects of some of the barriers I'll talk about are barriers that Maria faced, some of the resources are resources that helped Maria get the care she needed. And I divided in my head into these four categories. If you had a chance to look at the reading, there's lots of different ways to think about the barriers to healthcare access for immigrants. You can think about it in terms of culture and literacy. You can think about it in many different groups. This is the group that kind of works with my brain. So I start with government and society, thinking about what are the immigration laws, what is available to unauthorized immigrants, very little, what is available to refugees, something but not much, and this idea of local variation. If, for example, Maria had gone to 3 clinics and been turned away, would she have kept on trying? Some clinics have resources that other clinics do not. Some counties have paperwork that other counties do not. It can be very confusing for people born in this country to navigate the healthcare services environment, let alone someone for whom English is a second language, literacy is not. When I say institutional on here, I think about the clinic or the hospital, where someone is going to seek care. And when someone walks into a clinic or hospital, do they see signs in a language that they understand? Do they see people who look like them, who can speak their language? How easy is it to get there? I myself get lost in Harborview, where I have worked for 6 years. It can be a confusing place. And so how open and easy to navigate is the clinical environment, and how easy is it to get through the financial resources that are available there? At the level, I'm thinking about, someone like Maria. What kind of support does she have? When I met her, she didn't have a lot of support. And I see a lot of people in my clinic who are refugees who came alone. They're very isolated here. I have several patients on a regular basis. Right now I have probably 10 patients who are delaying much needed procedures or surgeries until more family can be here to support them. They're afraid to go through it on their own. And also difficulty with understanding. I think specifically for my refugee population where I work, but it's true for some immigrants, the level of health knowledge, the access to basic science education, or even access to health care in their home country was severely limited. And so just what is health care, what does it mean to go into a clinic can be a totally new experience for them no matter where they've been. Never have they been to a clinic, or never have they had the opportunity to learn to read or write or understand the organs in the body because schooling wasn't available to them. On a clinical level, when I say clinical, I think about who I am as a physician or a provider with the patient. We'll use the term cultural competency a lot. It means different things to different people. For me, it's how well I'm able to partner with the person who's in front of me to make goals, think about health, get them to a place where they're happy in their lives and able to do the things they want. But that cultural competency can be challenging. If I was someplace without robust interpreter services and really awesome medical assistance, it would be much harder to spend the time and do the work that is needed. I'll briefly talk about how some of these categories are also categories of resources. There's a lot of advocacy going on, of which Jorge is a part, to change some of the immigration laws, think about how we can make medical care more accessible for immigrants. And on the local variation front, there's pilot projects going on in certain counties or certain states that are allowing more preventive care for immigrants that hopefully will create change on a nationwide level. I am pretty proud of how Harborview is an institution and how many clinics have really looked at how they can communicate with their patients and make access better for their patients through community outreach programs. I happen to work with community house calls where we have cultural mediators and patient navigators who go out into the community and do education and help people make it through. And on an individual level, I have been astounded over and over by the resilience and level of family and friend and just country person support that goes on among my patients. People who have given food, housing, help people get to appointments, folks they've never met before, but they just happen to see they're in need. Also the level of understanding about someone's individual healthcare problem. It may not be the same as my understanding, but often it's a way that works and we can find a way to make things work together. I've talked a little bit about what, for me, is an important clinical resource. I'll wrap up here with just a minute or two, very general overview of some of the different paths that people take. So I see a lot of refugees and asylees, so they get 8 months of medical services, and then that ends. After that, they are eligible for Medicaid if, for example, they're disabled and unable to. Not everyone is eligible for that. The hope is that in those 8 months, you've gone out and gotten a job and gotten health insurance, or gone out and gotten a job and figured out how to pay for health insurance. So it can be really challenging. Those 8 months are very brief. For lawful permanent residents, those are people, for example, who were brought over on immigrant visas or sponsored by family members. They have a 5-year ban. And Jorge, help me out if I get some of this wrong, but this is my very basic understanding. My social worker has all the ins and outs. But they have a 5-year ban on receiving many services. And for unauthorized immigrants, there really is nothing that is state that is really accessible for adults anyway. And there is emergency Medicaid for people who show up in ERs. Those were mentioned in some of the readings. And local programs, like I was able to access for Maria, free care, charity care, things like that. And then, as was discussed in the New York Times reading for this class, Dreamers have been excluded from the Affordable Care Act in terms of how we're helping them or not helping them. Stop there with my very brief overview and cede the floor to Jorge, and then hopefully we'll have all time at the end for a good discussion.
Thank you, everybody, and thank you for being engaged in this discussion. I think it's very important. I'm just going to touch briefly, and I think I'm just going to follow on what Alex said and some of the points that she made, because I think the point that I like to emphasize is how difficult, how big, and how huge immigration status is as a barrier in all of this conversation. And I'll talk a little bit about how it just goes, from the different stages in the immigration process. And so I was actually going to use your patient, I call them clients, your patients, Maria, and her experience. And it's interesting because I did a presentation, I think it was here about maybe a year ago or so. And after one of these events, this young woman came to me and approached me and said, very similar story. I'd come to the United States at a very young age, at the age of 4. And, she just wanted to figure out what her options were. So I just kind of talked to her briefly. And I told her, I said, unfortunately, and I think it's something that a lot of community members who are not familiar with immigration, kind of surprised when they hear that the fact that somebody came, at 3 months old and have lived here literally their entire lives, that under our immigration laws, that counts for nothing. In terms of being able to get immigration status. So that's the whole Dreamers thing that we've been working on, is to try to make sure that that does count for something in terms of being able to pursue status. So at the time when I talked to her, she didn't qualify for any kind of immigration options. Her mom's undocumented. Her sisters also came at a young age, and so she didn't have any family members. She's not. Unfortunately, at this time yet, an engineer or somebody with a master's degree or a baseball player who could get an employment visa. She doesn't qualify for asylum. I mean, she, being sent back to her home country, her birth country, I would say, of Mexico, she doesn't qualify for any of those things. And so, I unfortunately had to tell her, you have to kind of wait and see what happens. And, there's obviously some efforts. This was after 2010 when the DREAM Act had failed in Congress. And so, but I did give her my card, and on June 15th of last year, one of the first emails that I had that morning when President Obama announced this new program for deferred action for undocumented youth, this Dreamer program was from her. And she was like the very first slot on our legal clinics to be able to get it, and I'm happy to say that she's been approved. So she does have a work permit, a social security number, but she's not eligible for, health care. So there's some progress. She's got a job. She's already got a job. She's working. She's doing all these things. And so that's I want to start a little bit with the success story, but to see how limited that is and how a lot of people in this situation are still not eligible to apply. So people who, the other people that come to our, and I think it's just more broadly, I wanted to emphasize again how difficult it is for people to be able to overcome this barrier of immigration status. I mean, a lot of us hear, for example, about marrying a U.S. citizen or having a U.S. citizen as a spouse as one of the pathways to be able to get status, right? And so, you're probably seeing the movies, The Proposal, Green Card. You figure out which movie you like, depending if you like Sandra Bullock or not. And so that's like, okay, well, if you marry a citizen. So a lot of people know that they fall in love here. They've been living here for a long time. They come to our office and they say, okay, I've married a U.S. citizen. I'd like to start the process to apply for a green card. Okay, so we do an interview with them. We say, okay, well, how did you come into the United States? Oh, well, I crossed the border without permission, 15 years ago, and but I've been living here. I have a clean record. And we say, well, okay. Well, it is true that you can apply to become a permanent resident, but here's the thing. Because you came to the country without permission, you can't get the green card here. You have to, start the process, but then you're going to have to leave the country and get the green card in your home country. Well, that's expensive. I don't know if we can do it, but okay, we'll try to do that. You say, okay, but the moment you leave the country, because you've been in the country for so long without status, you're barred from returning to the U.S. for 10 years. What do you think a lot of the families that come to our office say when we tell them that? They say, well, what do you mean? The whole point of my coming here is because I want to, get my legal status, be with my family, and, kind of move forward. Well, in 1996, we decided to impose this 10-year bar on undocumented people who are here to prevent them from getting status as another barrier. And so, when people, and this is just, I'm just giving you a quick, a glimpse of the problems that we're facing with the immigration system, that, the reason that we have, oftentimes, like I hear in the debates and about how we had this surge of people come and, and it's like, no, we've always had immigrants. The problem is not that what's changed is not immigration. What's changed and what the problem is, the immigration laws that have made it so much more difficult for people to come here. When people tell me, oh, my grandparents came legally, I tell them there was no way to come illegally when your grandparents came here. And even for a lot, through recent memory, even up to 1996, people could legalize their status very easily. There was something called suspension of deportation. Senator Pete Domenici a few years ago during one of the immigration debates, talked about how his grandmother had been, about to be deported, but then she was granted suspension of deportation, which was effectively, an ongoing legalization program. I mean, if we still had suspension of deportation, more than 2/3 of the people who are here undocumented would probably qualify and would have already gotten their green cards, and we wouldn't be dealing with the huge numbers that we're dealing with today. So. Again, this is just a huge barrier. It's not easy for people to be able to get status. And the the other point with Maria, for example, well, Maria might come and say, well, I'm now married to my partner, because Washington State now, thankfully, grants that right to same-sex couples. So I'm married, I'd like to at least start the process. I'll wait the 10 years. Well, you can't even do that because federal law doesn't recognize same-sex couples, same-sex married couples for immigration benefits. So very big barriers on different fronts. And then obviously, the connection with healthcare is huge, and I think some of the articles you've seen, the huge problems, because it's hard enough to figure out your immigration status, but even if you get to deferred action, so you get this work permit, you've been told by the government you can stay here, but you're also being told you can't access health care. Same thing with the lawful permanent residence. Alex is exactly correct. You become, you go through this arduous process, you become a permanent resident, but then you still can't access health care if you need medical assistance. And then, we're fortunate here. I mean, I agree completely with Alex that, fortunate that Washington State has stepped up in many ways and tried to provide some coverage for people or some services to people in some of those gaps. But it's been very spotty. And it's the first thing that people are targeting when it comes to a budget shortfall. And so it's not going to stay the way it is, just because. It's going to stay the way it is, and it's going to improve because all of us are involved in trying to make sure that happens. And then the final thing that I would say, just again, the complexity of the immigration system over top all of these the benefit programs, and then the healthcare options for folks, it's an impossible, maze to navigate. I mean, it's even hard for me when people come to me and say, what benefits am I eligible for? It's a complicated issue for me to resolve as an attorney. And so imagine for people who are trying to navigate, who just came to the United States or who don't speak English, trying to navigate this issue. It's just mind-boggling trying to navigate it. So I think it's very important that we try to continue to work to make the system simpler, that it has coverage for everybody. And I think one of the things that has been most disappointing, and really I think ultimately the way that I feel like it's so important, I think part of the reason that I'm so glad that you're all here is we need to approach this as a matter of human rights. I think probably one of my most disappointing moments of the last 4 years was when President Obama gave the speech in Congress and made a specific point of saying under my health plan no illegal immigrant is going to get health care, and he used that term, and many of you may remember that because that was a "you lie" from one of the representatives. And I think that what was disheartening about that is, I understand the politics of why you wouldn't, want to provide coverage. I understand that. But making a point that, like we're going to deny health care to this particular group is problematic in that it sends a message that, health care is not, something that everybody should have access to, period. And that, and therefore that the people who are not, being excluded are somehow less human than the rest of us. So I think we really need to emphasize it from a human rights perspective. I think that's the framework that we should be employing, and I hope all of you will be involved in that, and I look forward to your questions.
Hi, thanks for having me here. I'm speaking now because I think the idea is that I bridge the gap between the medical world and the legal world in the medical legal partnership of which I am a part. Currently, I'm an attorney working for Northwest Justice Project, which is a statewide legal aid firm. We provide free legal services to low-income people in Washington. And I'm partnering with CMAR Community Health Centers, which is a network of clinics and associated services in Western Washington. I work with a couple clinics in South King County, and those clinics really focus on serving the Latino population. So I work with a lot of immigrants, and the clinics, the two that I partner with, are really focused on being culturally competent for serving Latinos. Almost everybody who works there, from the medical assistants to providers, are bilingual, and they really do a great job of providing culturally competent care. They're premised on the idea that being low income and being an immigrant in this country and accessing medical care is a challenge. There are barriers, and so they've really set up their system to address those barriers and understand what's called social determinants of health. I assume if you're here, heard of social determinants of health. The idea that poverty influences health outcomes. Social circumstances, behavioral patterns, environmental exposures, those have a greater impact on premature death than quality of health care and genetics. And so those social issues, all the things that happen outside of the clinic, all the things that people largely can't control, are impacting their health and their ability to improve their health, comply with treatment, show up to the clinic. So these social determinants of health, the recognition that these are impacting people's ability to improve their health, that's what it brings social workers into the hospital setting. That's what brought patient navigators into the hospital setting, people who are there to help people from different cultures navigate the medical arena. It's what, for those of you who are interested in Paul Farmer's work, he provided stipends to tuberculosis patients so that they could comply with their treatment. It's the recognition that everything that's going on in somebody's life impacted by poverty is going to materially influence their ability to improve health outcomes. So that's why I'm in the clinics as an attorney. I'm there to provide civil legal services. So that means I help people with their housing problems, some family law issues, a little bit of immigration, public benefits problems, kind of the gamut of civil legal aid. So we provide in the Medical Legal Partnership direct client services, so I represent a client or a patient with their specific legal need. We also provide training to providers and medical staff to help them help patients with their legal issues that they might not need an attorney for. For example, we provide templates that are available to all the medical providers in certain areas so that they can more effectively write letters on behalf of patients. We find that providers spend a lot of time writing letters for patients, and it's not really what they're trained to do. So we want to make it a little bit easier for them to include that legally triggering information. For example, a senior citizen came into the clinic the other day. His water, his electricity had been shut off for 6 days due to some billing problems. And he had diabetes, and there's a law in Washington that says that if a medical provider certifies a medical emergency, then Seattle City Light, Seattle Public Utilities needs to turn the lights back on, needs to turn the water back on. And so we directed his primary care provider to the template, and the provider, filled it in and sent it in, and we're waiting to hear when his lights will come back on. But it's a way to leverage those resources that are already there, helping patients with just one attorney working in 2 to 3 clinics by training the providers and providing these resources. We can hopefully help more people. We also do a lot of systemic advocacy. Once we identify an issue that is impacting a large portion of the population, we can design some sort of impact litigation strategy to address it, so that by engaging in one big lawsuit, we're helping a large number of people improve their situation. For example, recently this doesn't immigrants, but recently we improved access to autism services for low-income children in Washington State. So hopefully about 8,000 or 9,000 kids who are low-income in Washington will have better access to services. I hope that soon I'll be able to improve the quality of the housing in this enormous housing complex that's very nearby the clinic, one of the clinics where I work. It's very challenging. Housing is one of the examples of a place where medical legal partnerships can really be effective. So lots of kids have asthma these days, and we know that mold and animal droppings can make asthma worse. And so kids get sent to the emergency room. They get pumped up with steroids and sent home with medication, but they're sent home to these moldy houses with cockroaches, and they're not going to get better. They're going to go to the emergency room again if they live in those conditions. So this is a typical area where attorneys working with providers can be effective. We know the laws, we know what the landlord's duties are to fix up those apartments. Working with immigrants is actually much more challenging to do this. It's an example of where there's just more barriers in terms of getting healthy and in terms of accessing legal resources. I speak to a lot of people who've been living in their apartments for 12 or more years, like a really long time to be in the same apartment. And they stay in their apartments that long because I think largely they're afraid of what will happen if they apply for new housing, because we have all sorts of requirements. They're often asked for their social security number when they want to move into different housing. So I talk to a lot of people who are stuck in really crummy housing that's making them sick, and they're afraid to move out because they think that their landlord or another landlord is going to ask them for their social security number. What else? Rest. Other challenges that I see where things just don't seem to work as well for immigrants in the healthcare setting and the legal setting. So we know that a lot of undocumented people are uninsured because generally people get insurance through work and they hold jobs that don't provide medical insurance, or they work under the table. So a lot of what providers spend time doing at CMAR is figuring out a course of treatment that people can comply with given their circumstances. So we know that Latinos are disproportionately affected by diabetes. I think they're twice as likely to suffer from diabetes. It's really shocking when I spend time in the clinic how many people have diabetes, and they don't have insurance and they don't have money to pay for their medicine. And so providers, figure out what the cheapest medicine is, and then they send it to care coordinators who figure out what companies might give away that medicine for free so that they can actually comply with their treatment. I spoke with one woman who was, her provider applied for, or her care coordinator applied for free diabetes medication from Eli Lilly, so big drug company. Eli Lilly says, well, before we give you free medicine, you need to show us that you're not on Medicaid and that you tried to apply for Medicaid and you didn't get it. And she's an undocumented woman, and so she was forced to do what so many undocumented people are so afraid of doing. She went to the office where you apply for public benefits, and she went and she filled out the application and left the social security number spot blank so that she could get a denial to take it to Eli Lilly to get her medication. It is so complicated, and the benefits are extremely complicated to explain, as both of you spoke about. And even when you do qualify for these benefits, it often requires you to go into the office and disclose that you're an undocumented person so that the people in your household who do qualify for the benefits can get those. It's an extremely scary thing to do, and I spend a lot of time speaking to people about the practices of our government agencies and whether they'll disclose their immigration status. It's a huge fear that people have, and I have so much respect for them even just coming to the clinic and even just speaking to an attorney, because those are not easy things to do, even in this area where we generally have pretty friendly immigration enforcement practices. So I've used up more than my time, so hopefully I'll get to speak with you again later. Thank you.
Much for having us. My name is Awa Kone, and this is Faya and I will be sharing a little bit about our experience with area, especially with the Mali community. I am from the Ivory Coast, like we said earlier, and Fahia is from Somalia. And there's a third person in our group who's not here today, that's Risho, and Risho is from Sudan. So we have Ivory Coast, Sudan, and Somalia, and we try to put our hand in whatever we can put our hand in this community. Tonight, what we want to talk about is, tell you is that how you don't have to do something big. Yes, if you have money, if you have big, what do you call, program, you can do something huge, but small things also do make a difference. That's where we feel very good about it. Fahia is a DV advocate, and so is Risho, and they do a lot of work in the community. Trying to unite families, and I do some, and I also do some family law when things really have to separate the people. So So I'm going to talk a little bit about a little activity that we did with Somali women here, and then Fahia will talk a little bit about a DV. All right. So what happened was that we wanted to really find out what's happening in the Somali community, especially with women, immigrants and refugees. So we decided that we're going to have a focus group. So Fahia, Risho, and I. So we had a focus group with Somali women and also with Sudanese women, talking about the Somali women here tonight. And it's like, okay, what are the 5 top issues that challenges that you face in the community? Tell us a little bit about it. Okay, some of the things that listed were problem with, education, language, discrimination, talking about difficulties having proper childcare for the kids so that they can go and look for work, barrier to care, and then female circumcision was also. So we looked at it, we said, well, if you want to rank those, what will be the top 2 or something? So one of the things that came as one of the highly ranked was barrier to care, which is what Alex talked about here. Barrier to care. And so we like, gosh, how can we do this? Then we decided, well, let's just talk to them, find out a little bit more what it is that we can do. And they're like, well, we go to the doctors. So here are women who are eligible. So they're past that first barrier. They can access the healthcare service. But we go, but then we can't communicate. We can't talk to them. They don't hear us. We just feel like we're just talking to people. So we thought, well, let's see, maybe we can have something called a mini health fair, where we'll just invite providers, we'll invite the women to come, and then we'll just talk. And that's how I came to know Alex. But I knew Alex, so she got connected with us with her. So we had Alex, a physician, we had a nurse, and we had a midwife. And then we had. So we started talking, and they said, well, one of the first things is that we go to the doctor, and they're called to get an interpreter to talk to us. We can't have somebody live to interpret. It has to be on the system. We talk. And we can't really hear. We can't understand what the person is saying because it's a different dialect. But because they're doing us a service, we feel like we can't say no. So when we pretend that we can hear, we pretend that we're communicating, but we're not. It's like, okay, all right. That's when Alex said, oh, whoa, we didn't know that. We think that you guys are communicating, but they're not because different dialect. So it's like, okay. We say, well, all right, we can do something. But Alex said, well, you can say no, that I don't understand. I do not, because it's a right that this got to be able to understand that in order to get the care. If you can't communicate, I don't understand. It's like, really? We can say that? Yes, you can. So it's like, okay, that's one thing. The other thing is like, well, I go to the doctor and I'm trying to say, when I get, just by the time I finish saying hello, the time is done. And Alex said, well, you know what? We have 15 minutes. They're like, what? 15 minutes? That's all you have as a physician or provider to talk to me? That's not even enough time for me to greet you. Because I want to start from when I was in Somalia, when I was a kid, how things started. And you are like, oh, like, sorry, this is really how it works. So what we talked about is, okay, what do we do? Well, make sure before you go see the provider next time, you talk to somebody or you really list what is it that, the really, I'm here today because I have 3 things that I want to talk about. So get that out first. Then the doctor will know, or the nurse will know, okay, there's 3 things. And then you start enumerating those things. When you finish enumerating, then you start explaining, like, oh, okay, that's different, but that's the way it works. Because the doctor is not going to have 2 hours to hear you. So it was like, okay, those little things. And it was really powerful to all of us. To us who were trying to facilitate that communication, to the providers, it was like, oh, we need to change something. And to the woman to say that you have some power. You can say, I don't get it, or I don't understand, or I don't like this. So anyway, that was a really good, we felt like it was a good way to really train those people to help the women to feel like access to care that. And then you can talk about
and they enjoyed that one. Thank you to Dr. Alex. Because, now they list it. Or also they, think about what is important for them. when they go to the doctor. And then now they know if the person, they don't speak their dialect, so they will tell them to the doctors, I don't need this person. I will come back next time. Or over phone, I'm not comfortable. So that's what we did our health fair like the last year, October. But now we don't have more time to the more details about the Somali health minister. But when you go to to the clinic or to DSH offices or the legal offices, you how is immigrant women, they have a lot of the barriers and problems. Even now, the case I am working to the woman who just immigrated like 4 years ago this country, and then has 5 kids. She's dealing to the learning to the language, culture, and the domestic violence. So the husband is abusing her, and she doesn't know what to do. But the neighbor is called to the police, and then they help her to get protection order. And they don't speak to their own language, but they communicate somehow. And then when they took her to the court, she gets the protection order. They told her, okay, now you can go to serve your husband, to find someone in the community. She couldn't find it. And she go back to the court. She said, oh, still, they extended 1 month. But now she has it February 21st for the court today. Came through to community here. And now, Sister Awa, I have background of the DV, but right now I'm not working for the DV. Now I'm family advocate at Southwest Youth and Family. I can work with everybody right now. But still they know I was working to the DV, still they can come, and then they trust me because I am everywhere in the community, whatever I can do for my community. So I told her when she came what's happened, she explained to me, and then I give her the address. I told her to go. She didn't go, and then today I found someone this morning earlier. She went to drop for to 4th Avenue for the police department to serve him. You know, how is the immigrant woman they face when they come to this country? You know, if someone who speaks the language and they know for the legal, they can go there, they drop immediately, they will get served. But still he is sending text message, abusing her, oh, I will kill you, I will deport you back home, even though she is illegal here. She came as a refugee. But still, she doesn't know because he's been here longer than her. He knows what's going on. But a lot of the immigrants, if you go to other country to learn the language, culture, how do you feel? Plus weather, we came to the hot country, so we are not, you know, never seen the snow before. Just when I come this cold weather and it snow. So all those things they deal for to the Somali women when they come to this country. All immigrant women, they have a lot of barriers. So always help them to educate, but it's like our time is very short. So if you guys go in the field, please try to make to any refugee and immigrant woman when they come to build trust. When they trust you, they communicate somehow. Even they can find their kids to interpret.
Thank you for those very powerful and informative presentations. So we're ready to take some questions from the audience. We actually have a second microphone today. If you raise your hand when you have a question, we will run the microphone to you. All right, well, maybe I'll ask a question. Oh, Anya. Well,
huge issue for the community. And so I'm just kind of wondering if there's anything in regards to that that's being done.
I'll start with your second question. There is a lot being done south saying that many are settling there. Housing is less expensive. There's these services who we are. So, has just opened a beautiful new facility near the Health Point Burien. You know better than I do. It's near SeaTech, Kent, Angle Lake, if that means anything to people. And so they have mental health services there. Their Office of Refugee Resettlement is there. In the next few months, we'll be opening a center for survivors of torture there. It is affiliated with the clinic where I work. And so there are services heading in that direction, certainly, and already many there. Regarding the 8 months of the Office of Refugee Resettlement is a complicated place, but there are refugee medical funds that are given, and that is around case management, around mental health services, and medical services.
Yeah, I mean, and I think that so after the 8 months, I think there's the Medicaid eligibility, and that maybe I'm wrong. Somebody's watching. Survey says I was wrong. Anyway, but it goes back to the point that not everybody's Medicaid eligible, and so while they don't have the 5-year bar, the lawful permanent residents that come in through family visa petitions or other kinds of petitions that are not asylees or refugees have, there's still that issue of the eligibility criteria.
I have a question for the panel. What about children of undocumented status? Are there exceptions for them receiving vaccinations and primary care?
Yeah, so that's a huge question that we get, and the key thing is that if the child was born in the U.S., they're U.S. citizens, and so they're eligible for whatever U.S. citizens are eligible for. However, if the children are undocumented, there's no exception for being, well, I shouldn't say that. Actually, there is a big exception in Washington State, in that we have a program called Apple Health for Kids that covers undocumented children in ways that in other states don't necessarily happen. So they're not eligible for federally financed health care, but there is a state program. But I think one of the biggest barriers, and I think it was mentioned in one of the articles, is that and this is something that we often refer to as mixed status families, where the children are U.S. citizens or part of the family's U.S. citizen, and then there's parents or other people who are undocumented, is that there's tremendous fear in accessing programs. So those programs are very accessed because people are afraid. Because it does, the 2-year-old's not going to be able to apply for the program. It's the parent who's got to go and file the application, as somebody mentioned, and expose themselves. And we get a lot that question because people are afraid. If I go and apply, am I going to get turned over? And one of the things that I think is important, I didn't mention earlier, is keep in mind that we're talking oftentimes about government agencies, and in a lot of places like where I come from in Colombia, the government there's no this distinction between federal, state, and local that we have here. It's just the government. And so the governments, the people are trying to deport people, and that are actually doing a pretty good job of record numbers of doing that. And so we're asking people to go to the government to go file and submit some information. And so even though they may be eligible, I think there's a lot of people that are not accessing those programs because of the fear that if they come forward, that information is somehow going to lead to immigration enforcement.
I wasn't going to bring it up because it's such a complicated, unhappy topic. That's true. I work for an organization that is not allowed to represent most undocumented immigrants, which makes for a pretty awkward situation at CMAR because they say, oh my gosh, there's a lawyer here? You're going to help all of the undocumented people here fix their papers. And it's like, well, no, for a variety of reasons. The law probably won't allow that, and I can't necessarily represent them. What I do a lot of in my work is family law because I am allowed to represent victims of domestic violence, where the representation is directly related to helping them live free of domestic violence. I do a lot of U visas, so helping victims of domestic violence and other qualified crimes get some immigration status because they worked with the police or prosecutors to help bring the perpetrator to justice. I sometimes represent the children of families in mixed status families. So, for example, I'm working with a family where the child has some developmental disabilities and is having problems with school and with his special education. So he's my client. Mom isn't my client, which is allowed. So it is complicated, and certainly when I'm going in and trying to work in the healthcare setting and building trust with this organization that has staked their reputation on being a place of confidence for immigrants and undocumented people, it's a big challenge, and it's a bit of an awkward partnership because of that, but they keep me busy. You know, I have plenty of clients and I have plenty of people who I can work with, and even when I'm not allowed to sign them on as clients, I give them legal information and referrals, which you know, sometimes doesn't feel great, but it's what I do.
I'd like to add that the King County Bar Association also do have legal clinics in the community, which many of us volunteer at those clinics. Fortunately, we can't really represent folks through that, but we can provide legal advice and talking to them and giving them guidance as to sometimes who else to talk to. And sometimes from those, we also do take cases that we can work with. And your group does that quite a bit too. And I think this Saturday, actually, there's a DACA program at Des Moines, which some of us will be volunteering. So yes, so the funding is not great, but I think, like Amy said, we all try to do what we can in order to provide the help.
So this is kind of a bad news and some good news. I mean, so the bad news is that the restrictions. I mean, and this is just an example of you know, restricting access to even being able to advocate. So the restrictions on federal funding and state funding for legal assistance, you know, exclude a large number of people from being able to even advocate for themselves. The good news here in Washington State is that, I mean, so there's still the restrictions even at the state level, because the state funding is also restricted from working with undocumented individuals. You know, we do have, you know, a lot of, you know, what we call the Alliance for Equal Justice, that is the umbrella coalition of legal services providers, and we work hard to try to find resources to be able to provide assistance to people who are not eligible for those for the state or federal funding. But this is not a good time right now for that funding. We used to rely on a source of funding called IOTA, which is interest on lawyer trust accounts. That was like an unrestricted source of funding that could go to help programs like Columbia Legal Services, like us, like some of the volunteer legal service programs like KCVA, for example. And the funding for that program, because of the recession, has gone from $9 million a year to $2 million a year. That's the level that we're at right now. And so we've lost a lot of capacity over the last 4 or 5 years. So, you know, we're in better shape. If you go talk to, you know, in other states about providing legal services for undocumented individuals, they're going to be like, there's just nothing. There's no place to go. Here we have some places to go. We do have some resources, and that is a good thing, but we're still pretty short on resources. But that's a very good question.
So some of the legal stuff, I may defer to my legal colleagues if they know the laws on that. But I do know that Washington State also has, above and beyond the federal laws, very robust interpreter laws, much better than any other state I've worked in. And there are requirements around the amount people have to pass a test and pass then another test and meet certain criteria. Whereas in other states, often it's just, oh, you can speak that language, come on over. So it's nice that Washington State has a certification program for medical interpreters, social services interpreters, different levels of interpreters. And it is an expected and a requirement for health care of individuals, and it is not differentiated what their status is, to my knowledge. And so in-person interpreters we can't keep on staff in-person interpreters in every language. Harborview, on a daily basis, sees at least 80 different languages. On a yearly basis, many, many more. And so we have on staff interpreters in, I think, Anne, I'm looking to you, help me out here, I think 20 to 25 most common languages, maybe less than that, around there. And then we use telephonic interpreters for the others, recognizing that it is less than in person. There's so much more you get in person. We've tried to roll out some video interpretation to kind of bridge that gap a little bit. We used to have agency interpreters come in for the languages that we didn't keep on staff, but that's incredibly expensive, and with the recession, that got cut. And so there are ways as a provider to try and work around some of the issues with telephonic interpretation, having people repeat back to you what you just said. This morning was with a Tigrinian woman from northern Ethiopia, and she had a very complex issue, had been in and out of the hospital 3 or 4 times. I really needed to make sure she understood her medication dosings because they had changed 3 or 4 times to help make sure she stayed out of the hospital. And so me and the telephonic interpreter and her talked about her dosing 5 times. I had her say it back. I had him say it to me. I said, okay, say that again. Okay, say that again. And particularly with her, where she cannot read or write, I really needed her to say it to me multiple times to really make sure she got it. So there are ways, but that all takes time and you're limited. I tried to address some of your points. I think I did. Other comments?
I can just say that in terms of the legal aspect, sometimes there are places where we do bring interpreters. So the clients, either they know somebody who can assist us with, and Fahia has played an interpretation role for many cases that we know of. And however, if it's in court, then you cannot bring your interpreter. The court provides an interpreter. For some of the languages, at least here in the immigration court, for some of the languages that are more common, they do have interpreters that they do bring so that they can stay on and work on longer cases, on numerous cases. And there's a few times where they had to use a telephonic interpretation. It's much harder, much harder, because you can't really get the body language. You can't really, Alex said, you have to keep asking the client, make sure if you don't get this, you make sure you let us know. So it's certainly not the best, but unfortunately, I think that's the direction that's going, that having in-person interpretation is just going to be shrinking and shrinking, sadly.
Also, when we go to the protection order, when we get to temporary, we can interpret our client as advocate. But when is the hearing, because of the husband is coming or boyfriend, whoever is coming that time, as advocates, we cannot be. Legal interpretation, there is another interpreter. They order both of them, whether if they speak English or not.
Here, you brought up an excellent point, and that is, given the choice between a family member interpreting and a telephonic professional interpreter, the rule in our clinic and the law would be that you use the professional interpreter, right? Because there's a lot of issues around family members interpreting or providers using substandard language skills to give care because an interpreter is not available. And so we really, unless the provider is certified as an interpreter in that language, really try hard to make sure that it's a professional interpreter, because even though it's worse with telephonic than in person, it is still so much better than half an interpreter, like a family member who doesn't really understand word-for-word interpretation or some of the basic rules around interpretation. And, I also work with asylum seekers doing medical affidavits, documenting the physical sequelae of the torture that they've undergone. And for that, there's no state sponsorship for an interpreter. There is maybe once they get to court, but to do that medical interview, they usually bring a friend, and that can be very awkward, as you can imagine. And often those friends are inadequate interpreters at best. And so, access to interpreter services is available in some settings, but in other settings where it's definitely needed, it's not available.
Beth?
Thank you. I will start by the second one. I agree, and I think that should actually be done in more settings than just that. Because if you bring the people, the provider, the educator, the police, or whoever it is to the community, to the people, the relationship that's developed, it's amazing. It has much more impact on what will go on later than the person going always to the person of power position. So yes, I agree. The other thing, for the first question, yes, there is that power, and I think Jorge said that earlier, which is that the government, you're going to whatever office you go in, it's the government, it's a person of power. It doesn't matter if the person is just the person who's just taking the notes or the person really the decision maker, because people see that as that. And I think it's the same thing with providers. Same with school. You go to the teacher, but I think for us, we felt like at least this thing came out, so we know. And now it's up to our group, it's up to Fahia and the team to really keep reminding the women that this is something you can do. And if one or two can do it and see that it worked, then I think with that, they can let the other people know, and I think that will make a difference.
Just word of mouth, because when women go do something, it's work, and then they will tell to the friends and the friends. So that's how it's work, because they are not writing, send letters, but just word of mouth. And then when we have gathering, we ask it still that question. Okay, when you go to your appointment, what's happened? What you ask it for your doctor? So always we keep asking them. I have it monthly to the Somali women's gathering at my work. So always we ask it. And then if the person is new also that time to that month's came, they will educate also themselves, and then we keep telling what's going on.
And, that can be good and it can be bad. My program is based on the premise that it's really good that people trust their providers, because especially I think CMAR and clinics that do focus on working with immigrant communities, it's a trusted place. People go there. We give Know Your Rights presentations there because people know how to get to the clinic. They feel comfortable that if they're attending a Know Your Rights immigration presentation, that, well, it's at the clinic. I think I can do this, and it's going to be okay for me to go there. A provider says, you know what, I think that you should talk to our attorney. She's pretty good. And so when I contact them, they feel a little bit better about speaking to an attorney, which they may not feel as comfortable with as, maybe going to the clinic. So certainly CMAR has taken that, and I think many other places have taken that and turned it into an asset, because it's become a community place, it's become a place to get your resources, it's become a place to say, I don't know what's wrong, but I'm going to go and I'm going to tell somebody what's going on with my life, and hopefully they'll be able to help me out. So medical-legal partnership takes that as an asset, and I think that's one reason why it works really well in immigrant communities.
I'll take that one since I used to work in the facility. Well, so there's actually two detention centers. There's the Federal Detention Center in SeaTac, which is more focused on people who are being held on criminal charges generally, and then there's the larger immigration detention facility in Tacoma, the Northwest Detention Center. And that facility has, right now, it's probably, as we speak, about 1,300 to 1,400 people. It's the fourth largest detention center in the country, and the immigration detention center in the country. You know, the medical treatment, I think that the challenge with the facility is that the idea of the facility is that it's a short-term center of detention. You know, they talk a lot about the average stay is like 33 days. And that's true, but if any of you know anything about statistics, then, you know, the average is not exactly what you're looking at. You're looking really at the range of people. I've had a client who was there for 4 years and 2 days. And so they are set up for sort of like minor things, and then if somebody has a heart attack, you know, they'll call 911 like any of us would. I think where it really, what we've seen real problems has been with sort of chronic conditions, and particularly people who already had treatment in other facilities. And I've done some work with people at our Harborview on this. You know, the fact that like people were in a good treatment that had somehow been plugged into a place where they were actually, you know, despite their being sometimes undocumented, because not everybody who's at the detention center is undocumented. But people may have been able to access services, and then they get placed into the detention center, and of course now they can't access the services, and there's very little continuity because, you know, facilities sort of like thinking, well, they're only going to be here for a period of time, and so they'll just get shipped off somewhere else, and we won't have to deal with them. So we've seen a lot of, we've had a lot of concerns with the situation there, but, you know, more importantly for us, it's just that there's no reason to detain as many people as we're detaining. We're detaining 34,000 people each day around the country for immigration violations, and, you know, it didn't used to be that way, and we're continuing at the same, you know, path that we've been for a long time. So I think that more broadly is what I see as the main issue.
Got time for one more question? Questions out there? All right.
Well, I could write a lot on that question. Well, so I would say, I mean, there's two main things that I think we need to do. I mean, you know, there's probably a lot more, but let me just touch on two things. So one is, I mean, we got to address the people that are here. We got to address the people that are here, and we got to do it in a realistic and practical way. Because the more we put all these barriers for people to hope, you know, they're talking about like fines, you know, and so, okay. And then the Senate proposal is talking about a commission made up of like Southwest governors who would then decide when people are going to be able to give legal status. And I don't want Jan Brewer from Arizona, the author of the SB 1070, or you know, who signed SB 1070, to be the one who gets to decide whether undocumented people get legal status, because I have a feeling that's not going to happen. And so I think we really have to have a path that's realistic for people to be able to stay in the country. And the way I like to explain this to people, because I think, you know, I get the questions. I did a thing today at the Seattle Times, and we were getting all these questions, and people are like, well, you know, but, you know, people broke the law, you know, why are we going to do this? And the way I was thinking about it is, the situation we have right now is like having, a community where people have built houses and they didn't get the proper permit in the beginning, right? And the question is, okay, what are we going to do now? So, okay, people did break the law. They didn't get the proper paperwork, right, to come here. Or they didn't get the paperwork, in my example, to build a house. Are we going to tear down the house? I mean, would that make sense if the house is safe to live in? And do we want to spend all the money that it would take to tear down the houses, or do we tell people, okay, you're going to have to get the paperwork in order, pay the fine, and then we're going to move forward? Yes, there's been violations of the law, but we need to get over that. I mean, we get over that all the time in a society. We really just need to get over that. And so we need to make it simple. I'm actually concerned that President Obama himself is saying, that we need to get people to the back of the line, because I think that just perpetuates this notion that there is a line. There isn't a line for the undocumented people around the country. There aren't lines for those people. Again, if you're a baseball player, there is a line for you. In fact, it's a very quick line. There is no line. You just get in. And so we need to think that we need to stop thinking that there is this line, this mythical line that people are out there at. But the second thing is, but there are processes that are in place, and the problem is that there are some lines. I mean, so I take part of it back. There are some lines to get into the country, and if you look, I mean, if you have a computer, any of you can look up, just Google visa bulletin, and that gives you the dates of how long people have been waiting, and you'll see dates there from like 1990. There may be some 1989 dates. That's how long people have been waiting for the legal immigration process. Over 23 years, 24 years, and so not surprisingly, a lot of people have given up on that system. It just it's obsolete. Our immigration laws, the last time we really significantly revised the numbers and the categories was in 1965. A lot of things have changed since 1965, and we haven't reformed really our immigration system. The 1986 law didn't really reform those pathways or the visa numbers. It did grant, amnesty to some people, but we never reformed the system. And that's when people say that 1986 was a failure. It was a failure because we never reformed the legal immigration system. We got to have a system that's much more flexible and that really, conforms with the reality of our system. It's like having the quick explanation of our current immigration system is, it's like having a 20-mile-per-hour speed limit on I-5, and people are not complying with that, limit, and not surprisingly. And the other side is saying, we need more cops out there. If we have more cops, people will comply with the law. And I'm like, no. If the law doesn't make sense, people are not going to comply with it. If you have a speed limit that makes sense for our economy, for what we are, then you can enforce the law. But we can spend billions and billions of dollars more putting enforcement, and it's not going to work if the law doesn't make sense.
Also, the 5-year bar that was mentioned earlier would be a huge one, and really promote the health and stability of the communities that are here now, if that were revised or deleted. I was also thinking today, wouldn't it be great if they gave provision for the legal services that are going to have to be given to all these people? Because people can't do it without some legal advice. It's not a good idea. And I know that NERP mobilized a lot to address the deferred action program, and this is hopefully going to be so much bigger than that. And so we just hope, or I hope that it's by providing some legal services to help people in this situation, I think it would curb a lot of abuses that can happen when new big laws come around and people come into immigrant communities and say, we can help, really, really, we're going to help, give us your money. So, yeah, that's what I would like to see.
Great. Well, with that, I think we'll close. Thanks to all of our panelists tonight for great presentations. We have some food and drinks outside, and we'll see you next week for violence against women and children.
Those templates you described.
Absolutely. I was going to...